This is our first Lupus You program for 2023. And for this program, we'll be discussing medication management and labs. So here's a brief overview of our program. As you can see, we have a full agenda. I'll kick us off by sharing more about the Lupus Foundation of America, some helpful resources and ways that you can get involved. And as I mentioned, we are so excited about tonight's program, and we're so honored and excited to have our speakers. And I'll introduce them a bit more when we get to each of their segments. I also want to take a moment and thank our presenting sponsor, Aurinia, for tonight's program. So thank you, Aurinia. And then finally, just a few housekeeping items before we begin. I know that we've all been doing Zoom for a long time now, it seems like. But again, I just wanted to put a few reminders out there. So we do have time for a Q&A portion of our program. And so we'll be pulling questions for the Q&A part from the Q&A feature of Zoom. So at any time during the presentation, if you want to submit your questions down there, please feel free to submit them. There should be an option to submit your question anonymously if you want to keep your name out of there. And then we will try to answer as many questions as possible. But if we don't have time to get to your question, or if you have a more personal question, maybe not as general or even related to this topic, you can always reach out to the LFA Health Education Specialist, and that you can reach out to them at lupus.org/healtheducator. Then throughout the program, we will have polls that you can respond to and interact with each other. And I see a lot of people saying hello and where they're located at in the chat already, which is great. We love to see the interaction. And then finally, I wanted to remind everyone that this program will be recorded. You'll receive a link of the recording along with helpful resources and a post-event survey where you can submit feedback about tonight's program. That feedback is really important to us. It allows us to shape the programming that we offer you, as well as the topics. Great, so we have our first poll question. We'll give that just a second to pop up. Great, so the first poll question we have is, which topics for tonight's program are of most interest to you? The options are managing lupus nephritis, medications for treating lupus, making the most of your pharmacy visits, understanding lab work, medication compliance, or all of the above. And we'll give that just a little bit, probably about 30 seconds to get your responses. Okay, so it looked like we were having a little bit of a technical error there. So bear with us. So let's try this again. It looks like we should be able to vote on this poll now. So again, which of the topics for tonight's program are of most interest to you? Managing that lupus nephritis, medications for treating lupus, making the most of your pharmacy visits, understanding your lab work, medication compliance, or all of the above. Again, we'll take about another 10-15 seconds to answer this and then take a look at the results. Okay, let's make our final selections and go ahead and look at those results. So 16% are interested in managing lupus nephritis. 53% are interested in medications for treating lupus. 8% in making the most of pharmacy visits, 53% for understanding lab work, 10% for medication compliance, and 29% for all of the above. So all very important topics. So as I mentioned, my name is Ashley Holden, and I am one of the health educators here at the LFA, and I'm going to talk a little bit about the Lupus Foundation before we jump into tonight's speakers. And so I wanted to talk about our vision and mission statement. And to put these simply, our goal is to one day end the impact of lupus and its suffering while ensuring that we provide a comprehensive support and programs people with lupus need today. And here at the Lupus Foundation of America, we work to meet the diverse needs of all people with lupus, and our commitment has never wavered in our more than 40 years of service. Today, people with lupus are living longer, healthier lives than ever before, and we believe that the Lupus Foundation of America has truly played a significant role in that achievement. We remain committed to doing everything we can to help you navigate the complexities of lupus while rallying every possible resource to end it forever. Our programs are based upon 3 pillars, which include research, care and support services for people affected by lupus, and advocacy. We've really redefined lupus research to expand our efforts beyond just funding research grants. We are engaging all stakeholders to identify barriers that stand in the way of the progress and are setting a course to overcome them. And we do this by providing caring support for people affected by lupus. We know that this is a devastating disease, and we also lead advocacy efforts to bring more funding for research and services. So our approach is comprehensive and focused on achieving meaningful results that will make a difference in the lives of people affected by lupus. So we align our efforts and resources towards achieving 4 specific outcomes, which you can see here. And so the first is to improve early diagnosis of lupus by increasing awareness of signs and symptoms and educating health professionals so people with lupus can get prompt care and treatment. We also want to secure new, safe, and effective and tolerable treatments for lupus by advancing research, improving how new treatments are evaluated, and educating people about clinical trials. Third, we want to expand direct services and increase access to treatments and care by providing resources and advocating for improved health services and affordable medications. And finally, raise money and secure government funding to operate programs that help people affected by lupus. So please never forget, you are the heart of everything we do. People with lupus represent the heart and soul of our organization, and you are the central focus of everything we do. You are a constant reminder of our mission's urgency and serve to motivate us to continue this fight. We understand the emotional turmoil, economic hardships, and physical suffering caused by lupus. And because of you, we are motivated to work harder and faster to bring lupus under control so everyone can have a life free from lupus. So in the interest of time, I'm going to try to keep this brief. We do have a lot of different programs and services, but I wanted to highlight a few for this evening's program. So some of the things that are available to you include our expert series. This is our educational podcast from lupus experts. Our most recent episode explains the impact of invisible symptoms, the difference between a sign and a symptom, and how to discuss this topic with your healthcare team and loved ones. We also have numerous support groups across the country where people with lupus can come together. Even if you don't have one locally in your community, many of these support groups are meeting virtually. So hopefully you can join in one of those if you're interested. We also have Lupus Connect. This is our online support community where you can engage and ask questions 24/7, 365 days a year. We also have our National Resource Center on Lupus, or sometimes called the NRCL. This is your one-stop resource for all things lupus, from treatment to living and coping with the disease. It aims to ensure that anyone affected by lupus, including people diagnosed with lupus, caregivers, healthcare professionals, people that think they may have lupus, all have access to high quality resources that provide emotional support and clear, accurate information. We know that there can be a lot out there on the internet, so we want to make sure that you have a good resource for that accurate information. I briefly mentioned this earlier, but I want to highlight them a little bit more. We also have a team of wonderful health education specialists, and our health education specialists are especially trained to provide people affected by lupus with non-medical support, disease education, information, and helpful resources. Some of our health education specialists are working behind the scenes during tonight's event, helping to answer some of your questions in the Q&A box. I also want to mention that we even have 2 bilingual health educators that can answer your questions in Spanish. Tuck that little gem in your pocket. If you should ever have a question in the future, you can reach out to them. Or if you have someone else in your life, a loved one or a friend that has lupus, if they ever need that resource, let them know it's available to them. I also want to mention Take Charge. This is a 12-week email series designed to provide information, tools, and resources to help you better manage living with lupus. And I know that tonight we're talking about medication management. So I wanted to make sure that we really highlighted our new program, SELF, which also stands for Strategies to Embrace Living with Lupus Fearlessly. And this is our free online self-management program designed to help people living with lupus really live their best life. And so this is essentially your virtual coach, and that virtual coach can help you manage your lupus symptoms, manage stress, manage medications, and work with your healthcare team. It's convenient and customized to your needs. It offers easy to use tools, trackers, information, support, and reminders. So make sure you check that out by visiting our website. You can go to lupus.org/self. So if you have some interest in getting involved with the Lupus Foundation of America, I really wanted to shed light on our upcoming National Lupus Advocacy Summit. This will be our first time since 2019 where we will come together in person in Washington, D.C. for the summit. This is the nation's largest lupus advocacy event. This year, it will be April 23rd to the 25th. And summit attendees will learn from experts in the field about the latest in lupus research, connect with hundreds of their fellow lupus advocates, and turn Capitol Hill purple by advocating for their members of Congress to join our fight against this terrible disease. If you'd like to learn more, if you'd like to register, again, you can visit our website at lupus.org/summit. So we have our next poll, and again, bear with us while we get that to come up. There's a bit of a delay with the poll questions. Okay, so our second poll question is, do you feel comfortable discussing medication and medication management with your care provider or care providers? And the answers are yes, no, it depends on the doctor and or medication, or I'm not sure. Again, we'll take about 10 to 15 seconds to answer this and then take a look at the results. Okay, let's make our final selections and we can take a look at this. Okay, so it looks like a good majority of you said yes. So 75% say yes, 2% say no, and 22% say it depends on the doctor and or medication, and 1% you're not sure. So that's great. So this is a great place to start since we have you all here tonight and we have some wonderful speakers. So I'd like to introduce our first speaker. And so we have Dr. Alvin Wells. And Dr. Wells is currently a practicing rheumatologist at Advocate Aurora Medical Group, where they're the director of the Department of Rheumatology in Illinois and Wisconsin. He is an assistant clinical professor at the Medical College of Wisconsin. He also maintains his clinical affiliation with Duke University Medical Center in North Carolina, where he's an adjunct assistant professor. Prior to returning to private practice, Dr. Wells was an associate medical director at Abbott Laboratories, where he played a central role in the launch of Humira. Dr. Wells received his medical degree from the University of South Florida, Tampa, and trained in internal medicine and in rheumatology at Duke University, where he was a faculty member before joining Abbott. He received his PhD in immunology from the University of South Carolina. He was a recipient of the prestigious Fogarty Biomedical Research Award from the National Institutes of Health, a member of the American Telemedicine Association and of the American College of Rheumatology. Dr. Wells has over 25 years of research experience focusing on chronic inflammatory diseases such as rheumatoid arthritis, psoriatic arthritis, and an emphasis on connective tissue components, inflammatory mediators, and cytokines. So Dr. Wells has a very impressive bio here, and I am honored and pleased to welcome you to join us this evening.
Thank you, Ashley, for that introduction. I'm trying to start my video, but it tells me the host has to do that. For some reason, start my video. There we go. Well, thank you all. Thank you for taking the time. And I just say kudos for Renia for sponsoring this program. I am a board certified rheumatologist, and here's what I tell my patients. At the end of the day, my patients are the customer. You're paying money for my best advice. So when you come into my office, you go to a doctor's office, that's what you should expect. You should expect the evidence-based medicine. You should expect FDA-approved drugs. And you should expect that that provider is going to treat you just like you are in somebody in your family. And if you're not getting those expectations met, then you need to think about challenging those providers to making sure you're getting that done. I like that people feel comfortable in asking the providers about how they do for the medication, because this is where you should be. And when we think about lupus, you know that many people who have lupus, 30% of them, when they walk into my office for the first time, will going to get kidney disease. So those angry cells that spill in the bloodstream get into the skin, causing that rash. They get into the hair, causing the alopecia, the hair loss. They can also get inside of the kidneys and attack the kidneys. And that's where we are when we talk about lupus nephritis. The next slide. You see here, we talk about what are the things we need to think about. It's a serious disease. Lupus itself is a serious disease. It attacks young ladies, particularly ladies of color, African American, Hispanic American, Native American. Caucasians get it as well, right? But the other patients of color get it younger and they get it more aggressively. So somebody asked in the question early on, my daughter was just diagnosed. Guess what? She needs to be hit very, very aggressively. I always share the story. I have a boy and a girl twin, and God forbid, if my daughter developed lupus and lupus nephritis, I'm not going to wait to see if older medicines from the 80s is going to work. I'm going to give her very aggressive treatment because I know the clinical data. So we know that it affects immune cells. Somebody asked the question, what's the difference in the white cells and the red cells? The red cells will carry oxygen that gives you the energy. Those white cells are the ones to protect our body from viruses, from bacteria, from cancer. But what happens in lupus, those angry cells go the other way and they start attacking the body, attacking the skin, the hair, the kidneys, and things along those lines. You see the second bullet point here, lupus can affect head to toe, all parts of the body, the joints, the skin, the brain, the lungs, the heart, and then the kidneys. And when lupus affects the kidneys, that's called lupus nephritis. On the right-hand side, you see about 50% of people who live with lupus may go on to develop lupus nephritis. Not everybody, but many people do. So I tell my patient, yes, I need to keep my eyes on you. I need to follow you regularly. And guess what? Every 3 or 4 months, I'm doing the blood work. I'm doing the urine because I don't want to wait to say, now you've got kidney disease and the cat's out of the bag. It's too late. Next slide. That's what the disease looks like. And when you talk about this, you know that it's a common complication of lupus, the inflammation of the kidneys. Some patients, once those angry cells start attacking the kidneys, they can go on and cause permanent kidney damage. Here's an analogy. We all had to take a little piece of stone, a little rock, and you rub it every single day on your hand. Every single day. Just do that for a strike. What's going to happen over a period of time? You're going to get a scar. It's going to get damaged. It's going to be a big scar there. You people might know some people of color who have the keloids. They get those ears pierced. They got these huge keloids that don't go away. And that's what happens with the lupus nephritis. So that stone that's eating away at your skin, causing that scar, those angry cells get inside of the kidneys and cause that damage. So my job as a rheumatologist, I want to block that. I want to keep those angry cells from slowly, over the years, attacking the kidneys. And once that happens, the kidneys can't function properly. And God forbid, many patients can end up with end-stage kidney disease and go on to cause in dialysis or require a transplant. And again, I have a sister older than me now who's actually just started dialysis. And I know that it can be challenging for patients once you add that to the program. Lupus nephritis can cause serious health problems. affecting the kidneys, and actually said can lead to kidney damage in some patients, transplantation or dialysis. Next slide. We know that it's not as uncommon as many people think. I get on a lot of my rheumatologists call, oh yeah, you're not going to worry about it. But you look at here, 100,000 patients currently diagnosed and living with lupus nephritis in the US. And those are the ones we know about. We say approximately because sometimes people don't really know it. They're not just, it's almost just too late when they get the swelling of the ankles. They get the shortness of breath. The blood pressure goes up. And then they say, wow, now you have kidney involvement. And like I said, 3 people will walk into my clinic to diagnose with lupus. One of those are going to be diagnosed with lupus nephritis before I even see them at diagnosis. So guess what? I don't know which of the 3 is going to be. So I'm going to screen everybody. We're doing the urine test. I'm doing all my other markers just to make sure we're looking at it. On the right-hand side here, you see the things I talked about. We know that the racial and ethnic groups have a higher rate of lupus and lupus nephritis than others, 4 times higher in people like African American, Asian Americans, and 2 times higher the Hispanic and Native American as well. So again, I tell my colleagues, if you see a patient like that, oh my gosh, if I had hair to make my hair stand up, because I'm gonna be watching out for them like a pit bull, just like it was my daughter, because I want to make sure she doesn't go on to be in that population that we see who can get kidney nephritis. Next slide. We know that lupus in general affects women more than men, but men can get it as well. So these are uncomfortable facts. Some of my colleagues don't like to hear that. Yes, 1 in 3 people with lupus can have it. Lupus nephritis diagnosis. Yes, people need to be seen frequently, every 3 to 4 months, and then they got to have the blood work and the urine every single time. Oh, Dr. Wells, I just peed in a cup 3 months ago. You need it again. Because I don't know when all of a sudden I'm going to see some changes in that urine. I don't know when I'm going to see changes in the blood work that's going to make sure now you got some kidney disease, and then we know that. Because look on the right-hand side here. Once you get that, I got to be very, very worried because you have a 3 times greater risk of dying from that, from lupus nephritis, from the infections, or hypertension, all those different things that we see. So these are the facts that we need to do. 3 people walk in the door with lupus, 1's going to have kidney disease. They need to be followed every 3 months based on the guidelines, evidence-based medicine. And then once we make that diagnosis, I got to keep my eyes on you like a hawk because I'm worried about some of the complications, including death. Next slide. So the complication related to this, like we're talking about, if the kidney's not working, you imagine it's a blood pressure, your body retains fluid, and when the fluid goes up, it makes the blood pressure go up. So we tell my patient need to monitor their blood pressure. I do a lot of telemedicine. I actually said I'm a member of the American Telemedicine Association. So I think all patients should have a blood pressure monitor. I can have that link. They can send me the readings directly from my patient. We know that chronic kidney disease, that's the scarring I talked about. That analogy, you take a little stone, you scrape it on your hand every single day. Well, what's going to happen in 1, 10, 5 years? And we know that many people to get the damage, it doesn't take 10 to 15 years, within 1 to 5 years. And then we know the cardiovascular complications. These young ladies with lupus can have heart attacks, they can have strokes, and some of them unfortunately can die. If the kidneys gets involved, they have a higher chance of going on to getting kidney failure, and we call that end-stage kidney disease. So at the bottom here, this is where the exclamation point comes in, catch it early. Somebody said, hey, their daughter was just diagnosed with lupus after having COVID. Makes sense, right? The COVID kicks up the immune system, and some of those angry cells in the immune system, they're going to go and attack the kidneys. They're going to go ahead and attack the skin. That patient needs aggressive therapy. Because my daughter, I'm not going to wait till she gets worse. You get one drug, she get better. Get another drug, get worse. I start aggressively up here to shut the disease down. And that's what we need to know. This early diagnosis and treatment, this all based on the evidence, guys. All based on drugs that are approved by the FDA because I want to prevent further irreversible damage. Because once that scar goes there, I can't get it back. I can't reverse that. And that's the thing we want to prevent. Next slide. So the signs and symptoms we talk about be swelling in the ankles. We all take our socks off at night. You have a little ring around the leg, right? It should be gone in the morning. If it's not, that's a call to your doctor. That's abnormal. Increased blood pressure. Again, I have high blood pressure. I'm on a blood pressure medication. My systolic blood pressure is 116. And somebody say, oh, my blood pressure is 130, 135, 140. That's abnormal. So we know that, hey, you need to be seen by the doctors. And then we talk about what does it look like with the urine. I'm old enough to remember we had the little milk cartons in school. You took the straw, you blew on it, and that straw, the milk makes those bubbles. That's what the lupus nephritis looks like with the urine. You go to the bathroom and urinate, and also you see all those bubbles down on the stools. That's because of the protein in there. Imagine blowing in the milk, like I said. Swelling of the legs, increased blood pressure, and then changes in the urine. So those are things you need to ask your doctor about. So what do I do as your rheumatologist? I'm going to look for your protein in your urine. I'm going to do a blood test to see if there's any changes. I look at your electrolytes and everything else that you see down here as well. And then there's some other things you'll see that we'll look at as well. Something called the glomerular filtration rate. That should be over 60. That means your kidneys are working like they should. Things are kind of going through. If it goes down lower than that, it goes down to 50, to 40, to 20, oh my gosh, we're in trouble. We got to take our eyes on that. Inflammation or scarring, going back to that analogy about the pebble, that's what I want to prevent, because once it happens, I cannot reverse that. So that's why sometimes you see I work together with my nephrologist. Hey, this lady's got some abnormal urine, blood pressure, and swelling of legs. I need a kidney biopsy. They lie you on the table, you numb it up, you go in and get a kidney biopsy, and I can look under that and say, hey, of the 6 different types of kidney disease, which one does this patient have? Is it one that I can treat, or is it one that, hey, I can't do a whole lot for it? Next slide. So the test to help you talk about, again, it's going to be urine test. And guys, every 3 to 4 months. I'm not going to do it once a year, because they come in a year later, again, the cat's already bad. I do the blood test, the same thing, every 3 or 4 months. Like clockwork, all the stuff is covered by the insurance. And when I see issues that I'm worried about, we do a kidney biopsy sooner rather than later, because I want to make sure there's no scarring or irreversible damage I want to catch before the cat's already out of the bag. Next slide. So your routine tests we talk about, again, don't be afraid about that. These are some numbers you know. So 0.5 grams, that's the amount of protein we should have in the body, in the urine rather. If we see anything above that, that's a sign of kidney damage. If urine results show that proteinuria levels of 0.5 or higher per day, it indicates you should speak to your doctor about treatment now. Guys, get this, there are tests that now you can do. You can buy these kits online. You can take a picture with your iPhone, and they'll tell you, hey, these are some abnormalities in the kidneys you need to let your doctors know about. Even if you feel well, many people don't have any symptoms. You want to ask your doctor about these routine tests, guys, every 3 to 4 months. You might only be seen every 6 months, but I'm still doing the blood work every 3 months. And then I can see the patient every 6 months to make sure they get in. Somebody asked the question, okay, what about the fatigue and the brain fog? That could be an issue that the lupus is active. I need to be very aggressive, get you under control, because guess what? The fatigue is one of the biggest things that we see in our patients. They go to bed, they say, I slept 6 or 7 hours, but I feel like I'm being hit by a truck. Because when the immune system is doing like this, guys, guess what? It burns up energy. Your body, you're sleeping at night, but your metabolism is going like this, and you wake up, you feel fatigued. So some doctors are crazy. They say, oh, no, let's go home. That's fibromyalgia. You need to get some more rest. You know, you got kids. No, I said, whoa, if that's my daughter, I need you to come in here. Let's do the blood work. Let's do the urine. Let's make sure nothing else is going on, because that could be a sign that you're getting the lupus nephritis. And that's why we are very aggressive in following these patients and treating them as well. Next slide. So choosing to prioritize your kidney health might be uncomfortable. I say not only for the patient, but sometimes the doctors, well, yeah, you got a little bit of protein in your urine. I don't think it's anything to worry about. Well, I said, doctor, isn't that abnormal? Should I have protein in my urine? Do you have protein in your urine? If he says no, well, I don't want it in mine. And that's what you push back. So I get on some of my colleagues, they don't treat people like they should, like they were somebody in their family. And that's how we have issues with disparities. You want to manage the daily struggles like we know lupus is a real deal, lupus nephritis. I mean, you're trying to take care of your disease, you got families, you got kids, all those can be a concern. Concern change to cancel and miss appointments. Guess what? You're not able to make it today, you got kids that are sick, you stay up all night. Guess what? You make sure you ask your doctor to do a virtual visit. It's covered by the insurance. Can you get on the telephone? Yes. Can you get on a virtual video? Yes. Still get the blood work, still get the urine, but you don't miss the appointments. So if I had a patient, I had 2 patients today that missed their appointments, guess what? My MA calls them. Hey, Mrs. Smith, you had an appointment with Dr. Wells. Want to say it's okay to do a telephone visit, do their refills, put the orders in for the lab. I pick up on the phone. I get on for at least 5 minutes and we go through their stuff. You don't want to miss an appointment. If your doctors say they can't do a video or telephone, you need a new doctor, because that's what the rules are. You don't need to go in as frequently as you think about it. And doctors will say, no, they can't do that. They're not going to get paid for it. They don't know what they're talking about. And on a daily basis, I see 40% of my patients virtually. About 25 patients a day, and about 6 or 8 of them are seen virtually. Don't even come into the clinic. I see them maybe once every 6 months. So there's no excuse to miss an appointment. You miss an appointment, you call the doctor, hey, can I turn it into a telephone visit? That's what you want to do, because I don't want it to go on too long. I know the questions to ask. I'm going to look at your skin. I'll look at your joints. I'll still need the blood work. I'll still need the urine, but we can do some of the stuff remotely. Next slide. So what is the goal? I want to encourage people to live with lupus. I like this whole program. I like the self program, that you can effectively live with lupus. It is a disease that's manageable. It's a chronic disease. You need to see your doctor. You need to be on medication. I need the blood work and urine, but we can follow this and do this thing appropriately.
You want to discuss all of these things with your doctor. Hey, doctor, I saw that one little thing said it was red abnormal. Would it be there? Or how do I get that into that normal range? Don't be afraid to ask those questions. If a doctor feels uncomfortable, oh, that's nothing to worry about. Whoa, whoa, whoa. Is yours in that range? Is yours normal? Well, mine's not, so tell me what I need to do. You see how you put the question back to the provider? Don't take no for an answer. Next slide. And then we talk about too, people into the cup of, like I said, it sucks. Dr. Wells, I just did it 3 months ago. I need it again. Okay, because I know when you got too much in there, it might be too late. And like I said, you want to make sure you talk about that. Swelling of the ankles, look at your blood pressure, and then making sure that I don't see that frothy urine. Don't be afraid to look down in the water once you get up off the toilet, because we want to make sure that there's not any signs of kidney failure, because once it gets there, I'm a whole lot I can't do. Next slide. You are your best own advocate. You are the customer. You are paying patients, the doctor, for your best advice. If you're not getting that, that's what you should be thinking about another different provider. I like the resource that we talk about here, getuncomfortable.com. Today, you can scan the code here and ask some question, ask your specialist. I tell my patient to write everything down. They come in here already, bring another pair of eyes and ears with you. Have somebody asking those tough questions for her. Hey, she's still having fatigue. Yes, her ankles are still swollen. Hey, I'm seeing all the stuff what's going on with the urine. That's why you need another person in the eyes and ears. You are the best advocate. You are paying the money. And doctors don't admit it. Whether it's Medicare, Medicaid, or other insurance, they're still getting paid. Next slide. So those are my thoughts here. I think as a rheumatologist, I'm very, very excited to be able to participate with this program. And if you have questions, I'll kind of keep my eyes on those in order and answer those in the chat. Ashley, I'm going to turn it back over to you to introduce the next speaker.
Thank you, Dr. Wells. And that was excellent. And I think that we all can agree that early diagnosis and treatment is key when it comes to lupus nephritis. And I think your energy was absolutely wonderful. And I see a lot of questions in the chat and Q&A. So I know we'll have a lot related to this topic when we get to the end. And as you mentioned, I want to introduce our next speaker, which I also am super excited to introduce. And I'm going to apologize before I jump right into his biography and my pronunciation of his name. But I would like to welcome Dr. Advocacy, and he is an associate professor and interim dean at the South University School of Pharmacy in Savannah, Georgia. He holds a pharmacy degree from the University of Ibadan, Nigeria, and a doctorate in pharmacology and toxicology from the Philadelphia College of Pharmacy. He completed a postdoctoral training at the Perelman School of Medicine, University of Pennsylvania, before joining South University in 2013. He has a passion for teaching, research, and optimizing patient care. Dr. Advocacy is licensed to practice pharmacy in the states of Georgia and Pennsylvania. He enjoys watching soccer and traveling. So thank you so much for joining us. The floor is yours.
All right. Thank you so much for having me. That was a great presentation from Dr. Wells. I think I'm just going to build on some of the things that Dr. Wells talked about. Please, next slide. So, I mean, going based on what we now know about lupus, we know obviously it's an immune disorder. And so the goal of therapy is always to, again, achieve remission. And if remission is not possible, we want to maintain low activity disease, and as well preventing the flares in all organs to minimize organ damage. Now, having done all that, we also want to use the lowest possible dose of our medication, because as you see, some of this medication, and I've seen some questions in the Q&A, some of this medication may have some undesired effect that may impact quality of life. So the goal has always been, again, to achieve remission or maintain low activity disease, prevention of flares. And so the key here is in consultation with your doctor when you visit your rheumatologist to, again, discuss with them all your options, all the options that you have. And as Dr. Wells indicated, be open about whatever your symptoms you're having, your concerns, communicating with your doctor. And then we'll talk about how the pharmacist can also help you to optimize the care of your condition. Next slide, please. So again, when you think of the drugs that are to be used in treating lupus, there are several factors that come into play. Obviously, the key signs and symptoms, those are the major factors. We talk about the organ involvement. So as you see, the differences in the treatment for mild disease, the moderate disease, as well as the severe disease. And also, there are also some drugs, medications that can be used depending on the particular organ that is involved. Dr. Well has indicated if you have lupus nephritis, there are certain medications that are indicated for that. If there are some other complications such as CNS involvement, other kind of involvement, there are other medications that may be recommended in that setting. Response to prior therapy, and so I know somebody also asked about prior use of prednisone and lack of efficacy another time. Again, that is something that we'll address hopefully during the Q&A. But yes, that's something that can influence the particular therapy that your doctor gives you. Adverse effect profile. I know a lot of times, those are things that can impair the quality of life. And so that's, again, something to discuss with your doctor as it relates to some of the adverse effects that you're seeing. And obviously, this is lupus is something that is very common in females of childbearing age. And that's something, again, that can play a factor in the medication that is recommended to treat the condition, because some of these drugs are not necessarily safe in pregnancy. Next slide. And so these are the class of drugs that are commonly used. Now, again, for organ involvement, for specific organ lupus complications, there are other drugs that may be used, such as anticoagulants. There's some, maybe even some antidepressant and some other things that may be used. But these are the ones that are used more so for general lupus without organ involvement. The most common one is the anti-malaria hydroxychloroquine. Now, it's not being used in for malaria in this setting. But again, all these drugs at some point in time, they're either anti-inflammatory to reduce the inflammation that is associated with lupus, or immunomodulatory, just to modulate the immune system, because we know that in lupus, the immune system is overactive, is hyperactive. And so we're trying to dampen the immune system. And so you could either have the anti-inflammatory, the immunomodulatory, just to modulate the immune system, or the immunosuppressants. And those are basically drugs that suppress the immune system. And those are usually reserved, again, for more severe conditions. So those are, you have the anti-malaria hydroxychloroquine, the corticosteroid, mostly the prednisone, methylprednisone, and again, the immunosuppressants. And I know somebody talked about asked some of that question about mycophenolate, Cellcept, methotrexate, azathioprine, cyclophosphamide, and there's some new drugs on the market as well. The voclosporin, lupicanase, that's a drug that was approved recently. And then the monoclonal antibodies, the belimumab, rituximab, and the anifrolumab. And while the non-steroidal anti-inflammatory, they're generally used as adjuncts, meaning that like usually used as add-ons with some of the other medication. By themselves, they're probably not the most effective in terms of treating lupus, but they can be used as add-on to manage some of the more milder symptoms of lupus. Next slide, please. All right, so I'll talk about hydroxychloroquine. This is probably a drug that is most commonly used for lupus, and it's relevant regardless of the disease activity or the disease severity. So whether it's mild, moderate, or severe, hydroxychloroquine is a drug that is commonly used, and it's highly recommended. It's been around forever. Obviously, prior to its life, its relevance for use in lupus, it was mostly used for malaria. And so it's relatively studied. It's been extensively studied. It's well tolerated. Now, it's important to know that it may take anything from 1 to 3 months to see maximal effect from hydroxychloroquine. But again, it's something that we know it's very effective. The key concern with hydroxychloroquine is generally the ocular adverse effect. And so patients that are given hydroxychloroquine, it's recommended that you get eye exam. But based on the studies that have been done, we know that typically the incidence of eye damage, retinopathy, is not as common in people that otherwise don't have any underlying eye pathology. So if you don't have any underlying eye pathology, and if it's not chronic use, so the concern with eye damage becomes more relevant with the length of use. So the longer the patient is on this, then the more concerning, or the more we are concerned about ocular damage, about eye damage. Now, it can also alter some of your heart rhythm. Again, while this is not really a concern for hydroxychloroquine by itself, we want to be aware of that because there are some other drugs that can produce an additive effect in terms of altering the normal rhythm of your heart. Next slide, please. Now, corticosteroids, these are again well used, extensively used for lupus. The most commonly used ones are prednisone and methylprednisone. They produce rapid symptom relief. And so typically, if you can use them in the interval between when hydroxychloroquine becomes effective, the dose and route of administration depends on the type and disease severity. And so ordinarily, if it's a mild disease, we're talking about using it orally by mouth. However, if it's something that is more severe, then we start talking about intravenous administration. The goal is to keep the dose as low as possible. And again, as soon as the patient can transition, as soon as you can transition from corticosteroid, we want to take you off that if at all possible, because we know that chronic use of this drug does come with some other adverse effects. And it's important to know that for corticosteroid, we do not want to stop it abruptly. And so even if you are having untoward effects, you want to call your pharmacist, you want to call your doctor, but really you do not want to just stop it abruptly. It's important that we taper the dose, meaning that, again, we try and reduce the dose of the medication that is used gradually over time. Next slide. Now, the immunosuppressants, they're reserved for more advanced disease, for more severe disease, and they can be used sometimes to facilitate the faster tapering of corticosteroid and also to prevent flares. Now, there are different agents in this class. The most commonly used are the methotrexate and azathioprine. They are well extensively studied, and we know that azathioprine is safer in pregnancy, although methotrexate is more efficacious. So that's something where, you know, if the issue of pregnancy comes in, that might be a factor that plays into it to say, okay, well, while we may want you to use methotrexate, we may have to put you on azathioprine. I know a lot of patients also use Celsep, mycophenolate. We know that obviously it has superior efficacy to azathioprine, but it is definitely unsafe in pregnancy. It is not to be used in pregnancy because, again, it can affect the baby. So cyclophosphamide is another drug, is another immunosuppressant. It's generally reserved for organ-threatening disease. Again, so you would typically not use cyclophosphamide in moderate disease. You want to use that in when there's a organ involved, significant threat to organ function. Now, we also know that cyclophosphamide is gonadotoxic, and so again, that's a concern when people are planning to get pregnant. Now, a new variant, a new derivative of cyclosporine, voclosporin, that's a lupicanus. And at this point in time, I added this because I know Dr. Watts was going to talk about lupus nephritis. This is the only oral formulation at this moment that has been approved by the FDA for lupus nephritis. Next slide, please. So these are the biologics. These are mostly administered via infusion. And so you will kind of need to go to your physician to administer this. However, belimumab, there is now a weekly self-injection formulation. And so again, but these are more reserved for severe disease. Anifrolumab, that's another disease. That's another drug, sorry, monoclonal antibody that was recently approved in 2021. It is only approved for lupus, not for lupus nephritis, because again, the population that was studied in the clinical trial, they were not, the people with lupus nephritis were not included in that trial. Rituximab is another drug that is used. However, it is generally used off-label because it's not FDA approved, but we know that there's several studies that have shown that it does provide some protection against the signs and symptoms of lupus, especially in refractory cases. Next slide. All right, so this is just a chart that shows you what kind of like a summary of what I talked about. You see that hydroxychloroquine is recommended across board. The glucocorticoid, generally low dose glucocorticoids, will be used for mild, and then we'll be talking about using orally. As the disease severity increases, we're talking about high dose glucocorticoids and then IV infusion, the immunosuppressant, methotrexate, azathioprine, and then the monoclonal antibody can then be layered on that. So let's talk about how to make the most of your pharmacy visits. So next slide, please. All right, so I know Dr. Wells touched on this, but the most important thing again is, you want to communicate with your healthcare provider. So in this case, you want to talk to your pharmacist. And when you're going to your pharmacist visit, whether you're bringing a new prescription or you're trying to get a refill, it's important to bring all the medications that you're currently taking. Again, because we want to make sure that we limit the potential for interaction. And not only the prescription drug, but there are even some supplements. There's some supplements that we take. There's some drugs that you can go and buy over the counter. Now, typically, if you're using a single pharmacist, that they would have all your records. but we know that about 4 in 10 of Americans typically use more than one pharmacist. And so it's important that when you present that prescription to the pharmacist, or you go to pick up your prescription, you let your pharmacist know all the other medication that you're using, because that gives a complete picture of your medication profile to the pharmacist, and they can then advise you based on the potential for interaction and on how to optimize the efficacy of your medications. Next slide, please. Again, communication is important. Communication is important because you want to make sure that when you go in there to your pharmacy, you want to be prepared to ask questions. And again, I understand sometimes, there's that hesitancy to ask questions, but like Dr. Wells said, you're paying for that service. Okay, the pharmacists want your business. They want you to come and patronize them. And so it's important to ask questions, because when you go there, you want to make sure that you understand each of the medication. Why am I being given this particular medication? What is the reason my doctor has decided to either increase the dose or to try and place me on another medication? You want to ask, how do I take this medication? What are some of the adverse effects from this medication? And what do I need to look out for? Those are very important, especially if you're starting a new medication. And more important, and also importantly, what should you do if you miss a dose? Okay, there are times where if you should you miss a dose after a couple of hours, we don't want you taking that dose again. We just want you to stay till the next time. And there's some times where within certain time frame, you may be able to just use that dose and continue on the regular way you've been using that medication. Next slide. All right, you want to also talk about any symptoms you're having with your pharmacist. And again, what to expect in terms of alleviation of signs and symptoms, because some of the factors that prevent patients from using the medication is, okay, well, I've been using this medication for the last 2 weeks, for the last 3 weeks, I'm not seeing any improvement. But at certain times, there's some medications that there's a lag between when you start using them and when you see a significant symptomatic improvement. How to taper the medication, especially your steroid, that's very important. That's something to discuss with your pharmacist. They can walk you through, okay, well, on this day you use 5, on this day you use 4, and things like that. Now, some of these medications can be quite expensive. And so you also want to talk about potential cost-saving options. Most of the companies, especially the new drugs, most of the companies will have some coupons that you can use to reduce the cost of your medication. Some of them may also have a plan where you can enroll, and that allows you to get the medication at a reduced rate. And there are also some of these medications that are already generic. And so instead of a brand, you may be able to get generic, again, provided that the efficacy and the component, the active ingredient, is the same. Next slide, please. Okay, all right, and that is all I have. Thank you very much.
Thank you so much. That was very informative and a lot of great information. And I can't wait to get to our Q&A portion in just a little bit. I know that was really helpful information. I'd like to introduce our final speaker this evening. So we have Dr. Duarte Garcia, and Dr. Duarte Garcia serves as the consultant in the Division of Rheumatology, leads Mayo Clinic's lupus program, and is an assistant professor at the Mayo College of Medicine. His specialty areas include systemic lupus erythematosus and antiphospholipid syndrome. Dr. Duarte Garcia conducts health services and epidemiological research and is the clinical lead of the Lupus Midwest Network, or LUMIN, one of the national lupus registries of the Centers for Disease Control and Prevention, or the CDC. Dr. Duarte Garcia's research is funded by the CDC, the Rheumatology Research Foundation, and Mayo Clinic's Kern Center for the Science of Health Care Delivery. So welcome, and thank you so much for joining us.
Thank you so much for the invitation. And also, I just want to highlight that the CDC registries are funded thanks to a lot of the advocacy that the Lupus Foundation of America has done. So thank you for that important work that the Lupus Foundation is doing. So in next slide, please. So we will talk about 2 things in the next 15 minutes. One is what are the common type of lab work that patients with lupus get. I've seen a lot of questions coming through the chat or the Q&A, and also the importance of taking your medications. So next slide, please. So there are a lot of different types of blood work that that we routinely get, the most common ones that we get are the complete blood count or the CBC. Will go, I'll review each one of them. Then the creatinine, urinalysis, erythrocyte sedimentation rate. Those are routine in every visit. And then there are some lupus specific type of lab work like anti-DNA antibodies and complement C3 and C4. I'll talk about those too. And then some that we use to identify if patients may have a higher risk of getting a blood clot, and those are called antiphospholipid antibodies. Next slide, please. So the first one that we will talk about is the complete blood count, and it has a lot of numbers and parameters, but not all of them are very beneficial or informative. So next slide. In general, the CBC is divided into the CBC and go back one, please. One before. Yeah, that one. So it's divided into CBC and differential, and the differential is just talking about the white blood cell count. So I don't think you need to memorize exactly what is happening with the differential part. The one that I want, the three parts that I want you to remember about the CBC or complete blood count are the hemoglobin, the platelets, and the white blood cell count. Next slide, please. So the hemoglobin is the one that is telling you how many red blood cell counts you have, and that's the red blood cells are the ones who carry the oxygen. Dr. Wells mentioned that as well. And when the hemoglobin is low, is marking that you have something called anemia. Most of the time, if the hemoglobin is abnormal, it will be on the lower side rather than the higher side. And the hemoglobin, when it goes low and it's called anemia, the anemia can be from lupus, it can be from medication side effects, or it can be from many reasons. But that's this marker, and is the marker that is more effective for red blood cells. And then there are other markers like hematocrit or erythrocytes or MCV. Those are not, I think, as informative. However, if you have questions about them, send a message or talk to your care team about the details of what those mean. But as I said, the hemoglobin is the most informative of those. The next slide. So then the other one that is important, go back one, please. I just have in each slide a red cell, so to be marking one of them. Yes, great, thank you. So the platelet count, the platelets are the type of cells that stop you from having blood loss. If you get a cut, they will stop your bleeding. And same as the hemoglobin in lupus, the platelets can be low rather than high. And usually around a number of 100 or lower is more concerning. But if you start to see them in red, that's something to discuss with your care team. The next slide. So the white blood cell count, there were a few questions about those too. So in lupus, also the white blood cell count can go low. Sometimes you see it on the higher side, and that's 10 or more. If you're taking prednisone or a kind of glucocorticoid or steroid, and if you're taking high doses of steroids, the white blood cell count can go on the higher side. That also will happen with infections, but the most common numbers that you will see in lupus are low white blood cell count. It doesn't mean that all low white blood cell counts are concerning, only when it gets really low. But most of the time, if it's close to the normal range, it's not associated with increased infections or is not of concern. Next slide, please. So the first group of labs was the blood counts, and then the next one that I want to talk to you is the creatinine, and this is a very important lab because it's measuring your kidney function, and the creatinine is often tied with something called the GFR. You may see it as eGFR as there. That stands for glomerular filtration rate. It's a mouthful, but this is the number that sometimes you hear doctors or PAs, nurse practitioners saying like, you have this much percentage of kidney function, like your kidneys are working at 50% or 70%. And it's not a perfect estimate, but it's a rough estimate of how much kidney function is left. And you will always see them both connected, both the creatinine tied with the GFR. The GFR is a little bit more informative because it's telling you that rough percentage of kidney function that is left. Next slide, please. And then the urinalysis. So the urinalysis has a lot of numbers. The one that I want you to focus more is in the protein part. And also because we're talking a lot about lupus nephritis today, or the inflammation of the kidneys from lupus, the protein should be normal. And when you start to see that the protein is up and usually marked in red in the apps or in your labs, that means that there's a protein that is being leaked and is a marker of lupus nephritis, and it needs to be checked. The urinalysis, the urine test being in the cup, should be checked in every visit to the rheumatologist. And of course, if you're going to a kidney doctor, to a nephrologist, they should be checking that. But if your rheumatologist is not checking the urine, is something that you should ask for. This should be checked in every single visit, even if you don't have or haven't had kidney involvement of the lupus. There are other two that are important, and I put the arrows there. So the red blood cells and the white blood cells. These are the same cells that are in your blood vessels. They can sometimes leak into the kidneys too. And when there are red blood cells, it can be that the kidneys are inflamed. Sometimes it can be related that the blood sample was taken around the period. And then white blood cells, when they are high, they can be also a marker of infection. You should not have white blood cells in the urine. And then next slide, please. So the last lab work that is not specific from lupus, but is used in every single lupus visit, is erythrocyte sedimentation rate. And this is a marker of inflammation. It's not specific of lupus. It can go up with an infection. It can go up if you get an injury or you get a surgery or something like that. But if you don't have an infection and you don't have a surgery or an injury, it follows inflammation in the body, and that can be related to having a lupus flare or lupus disease activity. For example, in the one that I have here, in the top one, that was related to a lupus flare, and you can see that the numbers were like 20 or 30 most of the time, and then in the flare it went up to 100. So is not specific of lupus, but it can go up in a lupus flare. And then the next slide, please. So then there are another 3 types of blood work that I want to bring to your attention that are used also in the follow-up of patients with lupus. So one is anti-DNA, the other one is complement C3 and complement C4, and then antiphospholipid antibodies. The antiphospholipid antibodies are not checked in every visit, but they should have been checked at least once, either at diagnosis or when you're meeting a new rheumatologist or around pregnancy. So those are not, antiphospholipid antibodies are not routinely checked all the time, but they should be checked at least once. Next slide, please. So the anti-DNA antibodies are one of the strongest markers of lupus. They are used to make the diagnosis. And once the diagnosis is made, they are also used to track disease activity. And these antibodies will go up when there's disease activity, when the lupus is active, and then they will go down with treatment, or when the lupus is starting to get in, activity starts to go down and the lupus gets under control. In this slide, I have, you can see that in 2020, the anti-DNA numbers were very high, but then a couple of years later, they have been trending down, and in 2 years later, they were half of what they were before. Sometimes it's not possible to make the anti-DNA negative and go away. In some patients, it will go away. In others, it won't. But it doesn't mean that if it's still present, there's still lupus activity, but it helps to track the lupus activity. Next slide. Then the complement C3 and complement C4 are other 2 lab tests. They are used also for diagnosis and to estimate disease activity. But these ones, instead of going up, they will go down when the disease is active or when there's a flare. They are always tested together, and you can see here I have a C4 and C3, and over time the C3 and C4 started to go up, so back to normal until they reach normal levels, and that's reassuring because it's telling you that the lupus is inactive or is under control. And next slide. So lastly, just wanted to emphasize again, checking for the antiphospholipid antibodies. And these are the ones that are associated with the sticky blood. You may have heard that. So when patients who have these antibodies, most of the patients have lupus if they have antiphospholipid antibodies. And these are associated with getting blood clots. The blood clots can be in the legs or the heart or anywhere. There are 3 types of antiphospholipid antibodies. You don't need to have all of them, but they should have been checked at least once. The anticardiolipin, beta-2 glycoprotein, and lupus anticoagulant. Again, if they don't need to be checked in every visit, but if you're meeting a new doctor or you're planning to get pregnant, I think it's important to get those checked. And of course, if you happen to get a blood clot, like if you get a clot in your leg, these need to be checked. Next slide, please. So now we will talk a little bit about the importance of taking your medications, and it will overlap somehow with the previous talks, especially with the previous one. Next slide, please. So just very briefly about the benefits of taking each of these medications. So the hydroxychloroquine, you just heard a lot about it. The hydroxychloroquine is a medication, or Plaquenil is a medication that we recommend to all lupus patients. And all the patients with lupus are recommended to take this because it decreases the number of flares, it reduces the risk of blood clots. If somebody with lupus is pregnant, is more likely to have a successful pregnancy, and also improves the survival. So this is a very important drug, and we will answer some questions about the eye testing. I saw a few questions coming up, but we will address those during the Q&A session. And then you heard also about the CellCept or mycophenolate, the lupkinase, voclosporin, tacrolimus. So all these are used for lupus nephritis. And even though lupus nephritis doesn't hurt, it doesn't give you symptoms of pain. It's important to take these medications if you're not feeling that many symptoms, to quiet down the inflammation in the kidneys. And then there are other drugs like Benlysta. I didn't include the IV drugs because the IV are given by somebody else. You're not responsible to take them. But the Benlysta there's an injectable drug, and this one decreases lupus inflammation in patients with kidney involvement or without kidney involvement, and also decreases the number of flares. Next slide. Now, it's difficult to take medications, and sometimes we ask patients to take a lot of medications, the Plaquenil, the blood pressure medication, vitamin D, the voclosporin or tacrolimus, or CellCept. You can end up taking dozens of pills, and that can be very hard. Sometimes you can get side effects from these drugs, and patients may not want to take the medications because they are getting side effects, they're getting nauseous or bellyache or some other symptoms. So make sure that if you think that you're getting a symptom related or side effect related to the drugs, talk to your doctors. They may be able to change the dose, or they may have an alternative medication that they can use, or give you tips like maybe take it with food, or to split the dose, or things like that may decrease the side effects, or just change it totally and prevent that you get further side effects in the future. Also, if you had to take a dozen of pills, it may be hard to take the medications, and is it may be easy to forget them. So sometimes your care team may be able to change the number of pills that you're taking. For example, if you're taking two 5 milligram tablets of prednisone, they might be able to give you one tablet of 10 milligrams. That may be easier to take than 2 tablets. Also, the Plaquenil now, it used to exist only in 200 milligram tablets, but now there are 100 milligram tablets and 300 and 400 milligram tablets. So you may not need to cut the medications, or you may not need to take 2 tablets, or just taking 1. So that's a way to make the drugs, the number of tablets that you're taking, a little bit easier. Um, there are a lot of apps for your cell phone that can help you to remind when you have to take medications. They are particularly helpful if you have to take them at different hours. So make sure you check those apps that are available, and most of them, if not all of them, are free. So they give you reminders, and you're more likely to reminded to take the dose. And lastly, there are some pill boxes that are very user friendly, and something that I recommend my patients, if they are taking a lot of medications, is on Sunday or over the weekend, just prepare, sit down, take a, have a cup of coffee, and go over your pill box for the whole week. That way, when the week hits and you're busy with work, or life, busy with your life, you don't have to remember every day how many pills of each one you have to take. And then if you sometimes you forget if you already took them or not. If you see that the pill box is already empty for the morning pills, then you know that you took them. You don't have to worry about taking 2 doses, or worrying about taking too much medication by mistake. Next slide. So also, cost is a very important problem. Drugs are very expensive. Um, Even the ones that are generic can be very expensive. So the drugs that are newer, like Benlysta, Lupkynis, or Safnelo, have a financial assistance programs. Not everybody qualifies for them. For a lot of patients can qualify for them, and your care team can connect you with these programs to try to decrease the copay or make it more affordable. Now, there are some generics that, they are not, they have been around. Plaquenil is one of them, has been around for 50 years or so, and the price has gone up a lot in the last few years. So there are a few pharmacies. There's one specifically called Cost Drug Plus that they don't work with insurance, but many times the price is lower than using a copay. And I'll be showing you an example of that one later. And then there may be resources available for your specific state, or sometimes for your county, or within your health system, that can help you to manage the cost and decrease the cost, at least the out-of-pocket cost of the drugs. Next slide. One before that one. There. So this is just an example. This is this cost drug, the pharmacy that I was mentioning to you. So Plaquenil is generic. They don't sell new drugs. It's just generics. But if you don't have insurance and you have to go and pay out of pocket, the Plaquenil sometimes is up to 700. So if you use this pharmacy, they will give you very, this is as low as the price can go, because it's what is the cost of making the drug. So it will go down to 34 for 3 months. I calculated this myself. And it may be even cheaper than your copay. Now, they don't work with insurance. So the copay, if your copay is lower than that, then you're good. But if your copay is higher, then it's some options that you can explore to keep the cost of the drugs as low as possible. Next slide. So last couple of thoughts here. Sometimes you may feel that the medications are not working, like you may not have any pain, or you're not having any rashes. The symptoms are feeling, you don't have symptoms, or you don't feel that the medication is helping you with the symptoms that you're experiencing. Nephritis, that when the kidneys are inflamed, is a very serious manifestation of lupus that may not give you symptoms until it's too late. So make sure that you're taking your medications, even if you're not feeling that they are helping you, and discuss with your care team, like, I don't feel this drug is helping me. Do you think we can stop it or change it? And they can show you, maybe through the labs or other ways, that the drug is helping you or keeping the disease at bay. And then I told you some tips about how to handle when you have a lot of pills, like maybe they can reduce the number of pills that you're taking by combining the doses that you're taking. Maybe they can redose it in a different way. Some patients prefer not to take more pills and may want to have an injectable instead, so may change the drug if it's available from an oral drug to an injectable. And there are other options to try to make this more manageable. Next slide. So just to wrap up again, so the CBC is the blood counts. There are three, all of them are relatively important, but three that are very important. The hemoglobin, that is telling you the red blood cell count and is telling you if you may have anemia or not. The white blood cell count, most of the time goes on the lower side in lupus. It can go up in an infection or if you're taking high doses of prednisone. And the platelets that also tend to be rather in the lower side rather than high in lupus. The creatinine is the kidney function, and is always tied up with this GFR or glomerular filtration rate. That one is telling you how much estimate of kidney function is still available. And then the urinalysis is a test that you pee in the cup, and it's telling you how much protein is in the urine. There should be any, and the urinalysis has to be checked in every single visit with your rheumatologist. The anti-DNA antibodies and the complement are used for diagnosis, but they are also used to track lupus disease activity. And the antiphospholipid antibodies should be checked at least once, and those are to check if you have a risk of having blood clots. Next slide. And lastly, also about taking your medications. If you take your medications, you're more likely to enter remission, you're more likely to live longer, prevent going into dialysis, and also prevent having lupus flares. Taking a lot of drugs is hard, and it's hard to keep up with all the pills that you have to take. But don't be afraid of asking your team and inquiring. Ask them, like, how can I make this easier? Can I take less medication? Can I take less pills? And they should be able to help you with that. And then make sure that you are taking advantage of apps available in your phones to remember taking your medications. Life gets very busy, so it's hard to remember to take the medications, especially if you're taking them at multiple times a day. And then pill boxes can be very helpful. You just take care of it once a week, and then you will have everything ready to go, and you're less likely to take 2 tablets or make mistakes by taking lower or higher doses of the medication. And I think that's all that I have.
Great,
Thank you.
That was a lot of wonderful information. And I want to thank all of our speakers for joining us tonight and welcome them all back onto camera and unmute themselves. We do have about 15 minutes, give or take, for some Q&A. And I know that I've seen a lot of questions come into the Q&A feature, and I want to give a big shout out to our health educators and our doctors when they were off camera who were responding to those questions. So we're going to go ahead. It looks like we have everybody here. And so we'll go ahead and jump right in the interest of time. And so this one looked like, Dr. Wells, you marked it as something you'd like to answer as live. And Dr. Duarte, you had also kind of hit on this as well, I believe. But this question is, I've been on Plaquenil for 25 years. So my ophthalmologist stated, this is the time I should start having eye issues. When is it safe to decrease this medication? And perhaps we could talk a little bit about the eye testing that should be done with hydroxychloroquine or Plaquenil.
So I'll start. So a lot of my colleagues say, we don't do the eye exams until you get to a certain dose or a certain number of years. And I totally disagree. I'm healthy. I have no eye problems. I go to the eye doctor every single year. And I demand that my patients do the same. We also have data to show, hey, there's a test we can do for hydroxychloroquine levels. If that level is 500 or greater, there's a higher chance that you have some ocular toxicity. And it is accumulative. We know for 5 or 10 years of hydroxychloroquine use, you have a higher risk of having ocular disease. And as you get older, we worry about the ocular changes from hypertension, ocular changes from diabetes. If you have those conditions, we recommend even more aggressive treatment. So we monitor the hydroxychloroquine level. My patients go at least every year for an exam. And then we try to say, hey, what's the lowest effective dose we need to get them under control using hydroxychloroquine? Dr. Duarte, you mentioned hydroxychloroquine. What are your thoughts?
Yeah, I think I don't think being on 25 years is, a reason just to stop the drug. I think what you mentioned, having the eye exam every year, that's the most important part. And the dose, if it can be lowered, I think they needs to be discussed with the doctor. But I don't think just being on the drug for a long time is a reason to stop it if the eyes are looking fine and are being checked at least once a year.
Great, thank you. So that actually brings me to my next question that Dr. Adeniji, you had marked as wanting to answer as a live, which is also related to hydroxychloroquine. And this is a two-part question. So you had mentioned that biologics are used as an adjunct. Have you heard of it being used alone for treatment of moderate lupus, non-lupus nephritis? And then what about the side effects that have been listed? And I imagine everybody might want to chime in here as well.
Yeah, so what I'll say about that is I think the drug was approved to be used in addition to standard treatment. And so it was not approved to be used alone. Now, if your physician wants to try it for a host of reasons, that you can certainly, there's off-label use, doctors are allowed to do that, but it was approved by the FDA to be used in addition to standard therapy. Now, I know there's been some concern about cancer and things like that. Now, any drug that suppresses the immune system significantly may increase your risk of cancer, typically lymphoproliferative disorders, lymphoproliferative cancers like lymphoma and things like that. But even with that, their incidence is low. Okay, the incidence is, well, we're talking about anything from about 12%. And so again, that's something that, we hopefully with proper testing and consultation with your doctors, they can make a better assessment. Now, while we're on that, I just want to talk about, I know there's a question about mycophenolate, cancer. Again, like I said, generally, any drug that suppresses the immune system can increase that. But there was a meta-analysis and that was just completed, that was published late last year. So meta-analysis is a study where they look at all the studies that have been done with regards to that drug. And they found out that mycophenolate really doesn't increase the risk of cancer when you compare it to not doing anything, not using any treatment, and compared to azathioprine. So the risk is always there. I don't want to give the impression that it cannot cause it, but compared to drugs like azathioprine, methotrexate, or not even doing anything, the risk, at least at that dose, is not significantly increased.
I agree. I think that one of the things we found that just by having lupus, your chance of having cancer or lymphoma is actually elevated. And we know that uncontrolled disease is part of it, drives us sick, because the immune system is there to fight, like I said earlier on, cancer cells. And if the immune system is preoccupied causing damage with lupus, a little cancer cell can sneak by in the lungs causing lung cancer. It can get into lymph nodes causing lymphoma. So guess what? I go back to using my daughter as an analogy. If she was diagnosed with lupus, I'm starting her on 2 or 3 drugs from day one. It's all based on the evidence. I do hydroxychloroquine, I'll give her a biologic, and even if she got kidney disease, I'm at the 3rd drug. I'm not going to wait till she's got 1 foot in the door for the dialysis center to start the aggressive therapy. And we're very aggressive. That's all based on the evidence. And I agree, Dr. Jenny said, yeah, start with the background therapy. I like mycophenolate. And then we add on top of that. And then as the patient get better, we say, what's the least amount? So I got some people on hydroxychloroquine that had issues. We go down to 3 times a week. I want to keep them on some drug to keep so that the disease activity under control. Some patients, we're not able to stop these drugs. We want to keep them under control. That was a question that came up earlier. Can they stop their drugs or stop it if they had side effects? We want to make sure that patients stay on some disease, a modifying drug to control it so they don't get things like Dr. Jinjay said about cancer and other things.
Great, thank you. All very good information. Dr. Wells, I'm actually going to come back to you and I'm going to try to combine a couple of questions and paraphrase here. But I saw a great deal of people asking about this. So, there are a lot of people that would like to know, in addition to taking regular lupus medications, are there any lifestyle changes, any diets or dietary changes that people should follow to decrease their chances of lupus nephritis? And along those same lines, maybe to help decrease the spread of lupus to other organs, And then maybe we could talk just a little bit, I'm throwing a lot in here, but about some of the early warning signs of lupus nephritis. Like I said, I know this is a really important topic. And so I'm trying to hit a lot of those questions I saw pop up frequently.
Well, I'll tell people right up front that I'm not a big fan of vitamins. In the old days, our grandparents couldn't go to Walmart or Target and get vitamins. What did they do? They ate the fresh fruits and vegetables, the fresh cheese, and milk, meat, things like that. Vitamins has fillers in them that have colors. You want to get the fresh fruits and vegetables. I know things are expensive now, but that's what we start off with. So we talk about our patient, what should it be? It should be healthy living, right? We're going to do low salt, high protein, and low carbohydrates. So if I tell people, like yesterday, I had waffles yesterday for breakfast, guess what? I can't eat that every single day. Tomorrow's going to be some eggs and some cheese and some turkey sausage, those kind of things. We talk about low salt, high protein, and low carbohydrates. And then making sure you get the fruits and vegetables. I tell my wife I could eat fish every day, but have fish, I tell patients 3 times a week, and limit the amount of red meat that you're eating throughout your diet. So those are the first thing that we talk about, but making sure your weight is under control. Here's one thing people talk about. I saw several questions. What about my fatigue? You got to sleep well at night. If you're not getting 7 or 8 hours of sleep at night, none of my stuff is going to work. Your immune system, you're like the little boy, if trying to put his finger in the dams, you're never going to keep up. You got to sleep. So that's when your body's immune system get a chance to relax and recover. Getting your blood pressure under control, controlling your weight, and being active. And activity doesn't have to be much. I tell people, hey, do some activity 15 minutes, 3 times a week, and double that on the weekends. And as you get more, you can say, now I'm doing 30 minutes 3 times a week and an hour on the weekends. So you slowly go up and doing something. That could be walking around the neighborhood. Where I live in Wisconsin, Illinois, here, no, we go to the malls. You walk inside of a mall and all those kind of things. So a little bit of activity. So sleeping well, eating right, controlling your weight, and all those different things is more healthy living. What are my other colleagues, any comments or things about that more globally on what's healthy living looks like in patients with lupus and lupus nephritis?
I'll just add that I think, again, staying away from light. I think everything Dr. Wells said is kind of on point, but you want to make sure you stay away from excessive exposure to sunlight. And if you must stay, and in addition to just general health, use sunscreen. I think it helps.
Totally agree. And I responded to comments about the using sunscreen. Some people, even as they're driving, holding the steering wheel, the sun hits their hands, they can get the lupus from that. So all those different things. So sunscreen is important.
I think all of these things are important for everyone, right? Everybody should try to abide by these, or at least do our best, right? And so I do have, I know we have a lot of questions, so I'm going to try to get through as many as we can. Dr. Duarte Garcia, what should someone do if their lab work is out of range, but their doctor doesn't seem concerned? Are there normal reasons why lab work might fluctuate or cause it to be out of range and their doctor not be worried about it at that moment?
Yeah, so that might be the case, that maybe it's just a small change. However, if you are seeing that the lab is looking abnormal and it's a reason for you to be concerned, I think that you should go ahead and ask them. Make sure that the question gets answered, like why is my hemoglobin low, or why is this number low or high? The doctor may not, or the provider may not be very concerned, but if it's a reason of concern for you, then they should take the time to answer and make sure that you're feeling safe and reassured about that lab if it's not worrisome for the doctor.
Great advice.
Actually, you question you ask about the early signs about lupus nephritis too, and I just wanted to make sure that we address that one. So
Thank you.
the lupus nephritis, when it gives you symptoms, is very late. So if you start, there are no early signs of lupus nephritis. So that's why you have to get the urine checked. The early sign of lupus nephritis is the protein in the urine. But that predates, that happens way before, or can happen way before you start to get swelling. So swelling is probably the most initial symptom, but if you start to get swelling, it might be late. So always make sure that the urine gets checked.
Thank you. Can I ask a follow-up question? Because I happen to see this and I'm going to kind of summarize what they asked, but what should someone do if their rheumatologist is not ordering routine urine tests or doing routine lab work at appointments at, frequent intervals every 3-6 months?
I will start that. I tell you, it definitely should be done every 3 months. And again, I might not see patients every 3 months. I might see them every 6 months, but I'm looking at the lab and look at the urine. One of the things we're looking at, proteinuria, protein in the urine is what we look for kidney disease. But we also want to see, are there other, what we call biomarkers or other tests that being developed? Can we determine, hey, does this correlate with the kidney disease? So if your doctor is not doing a test on a routine basis, I think it's time, I say, doctor, provider, you need to find another provider. It's just like, think about it. If you have a chronic disease like cholesterol, I'm going to be following my cholesterol level. You got chronic disease like blood pressure, I need to know what my blood pressure is. If you have lupus and lupus nephritis, I need to know what my numbers are. I need to know if there's any protein in my urine. And if your doctor or provider say, yes, you got a little 1+ protein in urine, nothing to worry about. Like I said early on, so, well, doctor, how much protein do you have in your urine? He says, none. Well, guess what? I want to make sure I don't have any in mine. And that's the kind of is, and this is why I can't give it gets very passionate, because it brings up all the disparities. The same things that I would not allow myself or my family, some providers okay with in their patients. And they're paying you money for their advice. And that's why we need the time for patients to empower them to ask the appropriate questions, and they kind of push back at the providers are not giving the best care possible.
Absolutely. We have to be our own advocates. We are our best advocates and can make sure that we get that care. As long as we're armed with that knowledge to know what we should be, getting done, right? And so I am going to ask Dr. Adenji, I have one last question for you. Someone had popped into the chat and said, you mentioned the need to taper from prednisone. They asked if you could talk about what happens if you don't taper. And I also am going to combine this with the second one that talked about how our body can naturally produce small amounts of prednisone. So is there a need to take a bigger dose in order to get a benefit from that?
All right, so I'll address the second question first. Even though the body produces normal level of corticosteroid, prednisone is an exogenous steroid. The steroid that the body produces is your glucocorticoids, cortisol. Prednisone is a synthetic corticosteroid that was synthesized, and the body does the same thing. But when you're using it, it means that the normal endogenously produced corticosteroid is not enough. That's why you're using the added corticosteroid. So that should address that. The challenge, the concern with abruptly stopping it is it can cause a flare. You can actually trigger a flare, in addition to some of the other effects. So with regards to lupus, yes, we wanted to taper it, but that's really not the only. In addition to the fact that it can trigger a flare of the signs and symptoms, there are also other things that are associated with prolonged glucocorticoid use. We know that, yeah, it can increase osteoporosis and some of the other things. And so we want to make sure that, yes, we're not creating a situation where you have rebound or withdrawal symptoms. That's really why we wanted to taper it, so that, again, we allow your body to get used to it. Because what happens when you use steroid is it kind of suppresses your immune system and it dampens certain normal processes. So the coordination between your hypothalamus, your adrenal gland, it dampens that axis. And so we wanted to give the body time to restore normal function in that as it relates to that axis before you just stop it. I don't know if Dr. Garcia and Dr. Wells want to chime in on that.
I totally agree. And I think that's what you see. We want to try to limit the exposure to these corticosteroids. And now we have data that just shows if for every 1 milligram increase of prednisone, there's a 3% chance you can damage an organ. That organ could be the lens causing cataract. The organ could be the skin causing these streaks or striae, we call it. The organ could be the bones. So we want to try to limit that. And that's why we're adding other newer drugs on that can limit exposure to prednisone.
Very good information. We are at time. And so I want to close out kind of asking each of you, if someone were to only take one piece of advice or one tip from your presentation, what would that one thing be? And I'll go ahead and go in order of the presentations tonight. So Dr. Wells, I'll start with you.
So every patient with lupus needs to be monitored and screened for lupus nephritis, period. And your doctor should be doing routine blood work and urine to making sure, not once a year, not every other year, every 3 or 4 months, because you want to pick up the disease sooner rather than later. And then your doctor should be using FDA-approved data that have been shown in clinical trials and not drugs that we discovered from the 60s and 70s and that I think are working. It should be drugs that get the disease under control sooner rather than later.
Thank you so much, Dr. Adeniji.
All right, so I'll just say that again, you're your biggest advocate. And so ask questions. You know, if you're concerned about anything, ask questions to your physician, to your pharmacist, ask questions. I think that to me is the biggest thing. And also, I'll kind of maybe steal some ideas from Dr. Garcia. Please, medication adherence is very important. I think this lupus is manageable and one can live a normal, can maintain a normal quality of life if you're asking questions and you're taking your medication as prescribed.
Ashley, can I add one quick comment? I'm glad we have a pharmacist on because in my clinic, we have a full-time pharmacist and a pharmacy tech, and they are part of my team. They help me with medications, prioritizations, and educating my patients. And that should be something that almost every patient should demand as well. So I'm glad to see our pharmacy colleague on as well.
They are an integral part of the team, most definitely. And then Dr. Duarte Garcia.
Sure. So I think it's similar to the message that was just given. If you have questions about your labs, there are a lot of numbers. They are hard to track, but that's why you're seeing your doctor or your nurse practitioner or PA to help you make sense of these numbers. And if you have questions, make sure that they are answered. Make sure that you don't be shy. They should take the time to answer them, either through the message, through the portal, or when you're seeing them. And then the medications are effective, but they only work if you take them. If you're having side effects or if you're taking too many pills, we also have now a pharmacist in our team as well, and they can also help you to optimize your regimen. So you're taking just the right amount of pills that you need to take, or make it as easy as possible. So that's it.
Most definitely, that is great advice. There are people that will just stop taking their medications rather than asking for ways to take them or minimize those effects. So I'd like to close out and thank all of you. You are all very wonderful speakers. We are so honored to have you join us this evening. And I wish that we had more time for questions, but unfortunately we are already over. But again, thank you, our speakers, and thank you for joining us for our first Lupus You event of 2023. We appreciate you for taking the time from your busy schedule to join our National Lupus You education event. We hope you found tonight's information helpful. For more information, you can visit lupus.org or you can contact our health education specialist.